everyone. A quick note about the next few episodes. We wanted to create for you a consultation in progress that I could relay to you and you could hear the types of advice that I give to my patients. But because of HIPAA, we couldn't actually use a real patient. So you're going to hear real patient questions, but not a real patient. And we hope that this helps you get the information you need for an in-depth discussion of a patient's symptom or problem. I had a very sweet patient who was not doing well at home. She had trouble getting out of bed, and she didn't want to continue with her treatment, but she wouldn't really tell us what was wrong. And the daughters would say that she would take pain medicine whenever they asked her, but she would never ask for pain medicine. And they really didn't think she was in a lot of pain. And I said, let's try coming into the hospital. Let's try putting her on a demand pump for pain and just see if she's giving it to herself without having to inconvenience you to go and get the medicine. How often would she need it? And she pushed that button 84 times in 24 hours. And she was finally able to rest. She was finally able to walk. And she was finally able to eat. And I think we don't take into account how people feel that they will be perceived for asking for pain medicine. And I don't think we take into account people who will take the pain medicine that you give them, but not tell you that it is not working. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. That opening story is still so moving to me because I remember that moment. But I didn't want to tell you that because I think that that's common for cancer. I really want you to know that that is incredibly uncommon. And our goal today, our goal in talking about pain and cancer pain and how to treat your pain is to avoid that scenario. And I think with a combination of good communication with your team and kind of a couple of hints in this episode, that absolutely can be avoided. So today we're going to be talking about pain. And I want you to think as we're talking about this, what's the worst pain you've ever had? For some people, it's childbirth. For other people, a kidney stone. For me, I've had both of those, and I still feel like there's a mauled by a bear level that I haven't quite experienced. So, we tell patients to look on the pain scale and to tell us what their pain is, but everybody's scale is different. And what might be a severe pain for you might be moderate pain for somebody else. So it's really hard to know. But I will say that every patient I have taken care of with cancer worries about the pain they might experience and wants to make sure that they have the best experience possible with the least amount of pain and suffering. And I get that. We all want that. So today we're going to talk about pain. We're going to talk about pain with cancer. We'll talk a little bit about pain after surgery. We'll talk a little bit about what cancer treatments do for you in terms of pain, and also a little bit about how to manage your pain at home. Now, this conversation should never take the place of a conversation with your specific physician about your specific pain. But what I hope we leave you with is a sense of empowerment, that there are lots of different ways to treat pain, and the knowledge that we are not going to let you suffer. And that there are many, many different things that we could do. And even if we haven't found the thing for you yet that is really helping you to live your best life, that there's still other things to try. So let's dive in.
Thanks, Dr. Pierce, for taking the time to answer some of my questions I have about pain. So recently I was diagnosed with cancer, and I want to know, how much pain can I expect during my cancer and my cancer treatment?
So the first thing we think about is that your cancer treatment is supposed to treat your pain, that as you have cancer treatment, whether that is chemotherapy that's going through your whole body or is a radiation type treatment that's very focused in one area, one of the reasons that we prescribe cancer treatment is to treat pain. Now, there are a lot of patients who are getting cancer treatments who are asymptomatic from an early stage cancer. And so in those cases, there might be some pain. In particular, the ones that we think about is the bony pain from the blood cell support medications that are given to support the bone marrow and can give people kind of aches and pains. There are sometimes joint pain associated with chemotherapy and cancer treatment. And there are times that we see difficulties with constipation and gas pain related to either pain medication or to many of the nausea medicines that we give associated with chemotherapy and cancer treatments. Surgical pain is an obvious one, and surgical pain is different from cancer type pains in that it's very acute, but relatively short-lived. Most patients only need medicine around the clock for a couple of days, up to 72 hours. And for many patients, they're able to stop taking narcotic pain medicine within 7 to 10 days of a surgery. So there's a couple different things that we think about in terms of pain related to treatment, but for the most part, the goal should be that it's always getting better.
So there's a difference between the cancer pain and the treatment pain?
Absolutely. And your doctor should be helping you to sort out which one's which.
So I saw my doctor last week, and I wasn't having pain then, but I am having pain now. When do I need to call my doctor?
So it really depends on the severity of the pain. If you are able to be relieved with Tylenol, ibuprofen, or other kind of common medications over the counter, and we can go through kind of how to use those medications, then it might be able to wait until your next appointment. But for my patients who are in surveillance, who are maybe only seeing me every 3 to 6 months, I have a rule that if they're having pain that's out of the ordinary for them and is more days than not for more than 2 weeks, I want to hear about it. Because when we think about that, could this be indication of a cancer coming back? It usually is escalating, not what we call waxing and waning or getting better and worse. Usually not associated with injury. I do have people who call me after they stub their toe, worrying about the toe pain. So usually not associated with injury. But is the types of pain that we worry about are those that are getting worse and not better, and maybe not responding to what used to work.
Okay, you've mentioned this pain scale a couple of times. Where on the scale do I need to be before I call my doctor?
Well, there is no specific number. The point is that we want to teach you and your caregiver how to control your pain at home. And if your pain is persistently not controlled at home, we want to hear about it. So let's start with, what do you do at home? And, we used to think that we used to think that for any treatment, you start with one medication and go to the highest possible dose and then move on to adding another. And we've actually found with pain that really is not true. What we want to do is layer the pain medication to give you the best relief with the lowest amount or the least amount of pain medicines. So first we start with, think of your pain treatment as a club sandwich. So first we're going to start with the easy things at home, the Tylenol and ibuprofen. And those medications are very specifically, those medications, we do want to make sure that patients are able to take those and are taking them in the care of a physician, because sometimes we do recommend higher doses of ibuprofen or Tylenol that are on the bottle. And you can alternate those medications. Ibuprofen is cleared in the kidneys and Tylenol is cleared in the liver. So as long as you're taking what's prescribed to you or what is on the label, you should not get into danger by taking them in an alternating fashion. And for patients who are having difficulty with pain control, maybe postoperatively, we recommend that you do alternate those as frequently as taking one every 3 hours. So Tylenol, and then 3 hours later, ibuprofen. And that allows you to get the maximum benefit from both of those medications without needing something stronger like narcotic pain medication. The second level are medications that fall into maybe muscle relaxant medication or nerve blocker medication, which can relieve pain in particular for musculoskeletal or nerve pain. Both can work well for postoperative pain as well and can be layered on to the ibuprofen and Tylenol without any untoward side effects. Then, of course, we sometimes move into the narcotic pain medication. And for a lot of people who are asking, when do I take my pain medication? It's because they do already have a prescription at home that reads on the label as needed. And what does as needed really mean? So when we're thinking of the pain scale specifically, really we want to start thinking about taking a pain medication somewhere between a 4 and a 6. And that's different for every patient. Some people are more pain tolerant or are more likely to want to avoid pain medication. Maybe they have tried something else. But we really don't want you to get beyond a 6. And the reason that I tell patients that is because if you let your pain get what we consider to be out of control, which is the 7s, 8s, 9s, and of course, every pain that's a 10, but if your pain is out of control, it actually takes more medication to get it back under control than if you had taken the pain medicine when you knew you were in pain, but it was not severe. So for most patients, we usually recommend ibuprofen or Tylenol for that mild pain, adding on one of those medium level medications for moderate pain, and taking a narcotic pain medicine for more severe pain. And when to call the doctor is really, you have said, I've taken all of these, I've been through a couple of rounds of this, and the pain is still severe, meaning 7 or higher, and not getting better. In fact, if pain is getting worse, that is worrisome to us. Now, one side note, in particular related to abdominal pain, a lot of these medications and nausea medicines for cancer treatment and some treatments themselves actually cause constipation. And with constipation, we see a lot of abdominal gas pain. So if you're feeling bloated, you have more what we call colicky or kind of coming and going abdominal pain, particularly if it's associated with constipation, try Gas-X. It actually can relieve a lot of pain, as well as getting on some type of treatment for the constipation. Getting relief from that can make a lot of abdominal pain feel better. Even if your abdominal pain is related to cancer or scar tissue, having an empty colon goes a long way to helping your pain be controlled.
Okay, so I think I understand this pain scale a little better. So what other tools, like what are the words or descriptions can I use to help me explain my pain better to my doctor?
I think the first thing that really helps me is for you to be specific. Instead of having a headache, but I'm having a throbbing pain in the back of my head or a pain in my temple that comes and goes. So being real specific helps. I particularly find helpful, what you've tried already, what maybe gave you a little bit of relief, even if it wasn't complete relief, versus the things that didn't work at all. And, I'm always going to ask what you have already taken for the pain and in what doses and how frequently you've been taking it, because we do find a lot of patients worried that they might take too much, actually have not even taken the medication as prescribed. And so just that correction to go up to the doses that are prescribed really helps patients to get the relief that we expected when we prescribe the medication.
Yeah, I'm also super worried about taking medication that's going to get me addicted to anything. You see all these scary TV shows about opioid addiction and pain medication addiction, and you just hear all of these horror stories in the news.
So the first thing that we think about is we used to think that the right way to treat any problem was to take one medication and take it till you got to the highest doses, and then add a second medication if that medication was not covering it. And for pain, we've actually realized that that's not the right way to do it, that it's like layering. You want to think of your pain control like a club sandwich. So you want to start with the easy stuff, the ibuprofen and the Tylenol. If that is not treating your pain, there are other things that are non-narcotic that can be added to help. like a nerve blocker pain medicine, such as gabapentin, or a muscle relaxant, like cyclobenzaprine, depending on where your pain is and where it is in relation to the tumor. And after we have tried those others, we do usually add a narcotic, but that doesn't necessarily mean to stop taking the others. So the narcotic pain medicine, and I do want to make a note here to be careful. Some narcotics, if it has a CET, C-E-T on the end, like Percocet as a brand name, or anything that has APAP, anything that has APAP or acetaminophen on the bottle. Note that that is acetaminophen or Tylenol, and those products should never be taken with Tylenol. You take it instead of the Tylenol. So you could continue to take the ibuprofen when you need it and take that narcotic pain medicine with or without the combination of Tylenol as your breakthrough pain medicine. And so we actually want patients to use the least amount of narcotics that they can get away with and for the shortest period of time. So we don't want you to take it if you don't have pain. That seems obvious, but for a lot of patients, they're so worried that they might have suffering that they actually take it on the 6th hour, around the clock, all the time, just in case. And as you get further into your treatments or further away from your surgery, you really might not need that. In fact, if you're taking so much narcotics, you might actually find that your pain is related to constipation from the medicines themselves. And so we want to encourage you to take the least amount that you can get away with. Now, that being said, there are times when cancer patients, whether it's related to the tumor progressing or to a particularly painful area of cancer, that we will recommend that you take your pain medicine around the clock. And that is when my alert goes up, and it's just an alert. It's not an alarm, but that's when my alert goes up about the difference between using it for pain and using it for things other than pain. I guess that's what I would say. I think anytime that we are worried about addiction, that means that we're worried about using the pain medication for emotional reasons or to solve emotional problems rather than to solve pain. And so that's when we really start to worry. And that's when you should think about, is this the right time to take pain medicine for yourself and for your family? If you are a caregiver out there and you're worried about, mom keeps asking for the pain medicine around the clock, is this something we should be worried about? And it really is about making sure that you're taking pain medicine when you have pain. And if you're taking pain medicine when you have pain, I am not worried about addiction. And that means that if the need for pain medication escalates, then we escalate to what we call a long-acting pain medication. So long-acting pain medicine actually is more quote unquote habit forming, meaning you will develop a physiologic dependence to it and you will have withdrawal symptoms if you stop it. But it is an important component of pain control. It is less able to be abused. It can't be broken in half. It can't be cut if it's a patch. It is very hard for someone else to take that pain medicine and use it. And so getting to the point of long-acting pain medicine is much better than, for example, being prescribed, 100 tablets per month and taking those around the clock. We'd rather have you on long-acting pain medicine where you're only taking a tablet twice a day, but it is a long-acting pain medicine that controls your pain all day long and all night long. There are multiple formulations of long-acting pain medicine, including, as I mentioned, a patch form of pain medicine that even for those patients who are really having significant nausea can continue to control pain. At the end of life, there are some patients who need a pain pump. And I will just mention here that that is never intended to shorten a person's time and is never escalated to those levels. Rather, we use that pain pump to control pain so that patients continue to have valuable and interactive time with their family and to not have pain be the most prominent symptom. But we usually recommend a pain pump when the doses of the narcotic pain medicine needed to keep somebody comfortable exceed beyond what is safe to give by mouth or in those long-acting formulations. But the short version is, if you're taking pain medicine for pain, I do not worry about abuse, which is different from physiologic dependence. And We always want to make sure that a patient doesn't stop taking pain medicine suddenly, but anytime you're stopping or cutting back on your pain medicine, maybe your treatment is working or you've had radiation to that area of tumor that was causing you pain, that you wean down slowly on your pain medicine to avoid any physiologic discomfort associated with withdrawal.
So we've already talked about narcotics and pain medicine, but what are some other things for pain that we haven't discussed?
Yeah, there's a lot of alternatives to pain medication. We've talked through the most common pain medications that we prescribe, but there's a lot of other things that we can do. In particular, for musculoskeletal pain, we think about physical therapy and acupuncture even. Acupuncture is a great alternative therapy for a lot of the symptoms of cancer, and patients can have really great relief from it. There are local treatments, including things like injection of lidocaine into a particular pain point, what we call a trigger point. There is also steroid injections and both steroid and lidocaine injections of joints that are particularly painful. And sometimes chemotherapy makes those better and sometimes it makes it worse. So a little bit hard to say, and that can be a source for patients that can get relief in a particular area. There are also lidocaine patches, both prescription strength and those over the counter, that can be used if there's a particular area that's sore. We often use them around a surgical site, and these can be what we call narcotic sparing, meaning can help you to take the least amount of narcotics that you can get away with and avoid many of the side effects that we've already talked about. Sometimes for a particular area of inflammation, patients can do steroids, and those do help as an anti-inflammatory and help get relief from a particular area. So there are a lot of other medications to try. The other class we haven't talked a lot about is the class of antidepressant medications. So while these medications are not particularly geared towards pain, patients have found pain relief who are on these medications for depression or anxiety. So doctors often, if there's a combination of symptoms, particularly just a general malaise, low energy, a low mood or an anxious mood, and pain, sometimes you can actually try an antidepressant first. And that can be one of those layers in your club sandwich of pain treatment that helps you to avoid long-term narcotic use. So to recap, if you're cancering and you're experiencing pain, call your doctor or your doctor's office. And do be specific about what type of pain it is. Is it achy or sharp? Is it a headache or is it neck pain? Really be ready with your descriptions and maybe even write it down or keep a pain journal. So we want to know how often it is. Is it constant or does it come in waves? And what makes it better and what makes it worse? And we'll ask all those questions. And then your team can respond to those symptoms and really help you to manage it at home, or if not, in the office. And if it's really acute, of course, we'll tell you to go to the emergency room or to an urgent care for a more rapid evaluation and management. But in each of those settings, we're always going to make sure to minimize any pain and suffering, and that cancer treatments are designed to treat pain, not just to treat the cancer. And so I hope this has been a useful episode for you. I hope it helps you to feel empowered and hopeful that cancering does not have to mean a future of pain. Again, thanks for listening to The Cancering Show. And don't forget to submit your questions at cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the USA Health Mitchell Cancer Institute. MCI is a leading-edge cancer research and treatment center built to fight cancer in Mobile and Baldwin County. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment area of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com. or find us on Facebook, Twitter, and Instagram. The Mitchell Cancer Institute is a member of USA Health, the health system for the University of South Alabama. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.